My name is Zoe. I will be moderating the ED Access Crunch Heat and Interpersonal Violence session. Thank you for attending today. I would like to introduce our panelists. We have Dr. David Neeson, Emergency Medicine at Kaiser Permanente. We have Dr. Brittany Voth, MD, MPH, at Pediatrics at UCSD and Rady Children's Hospital Residency. And we have Emily Sabroli, Emergency Medicine, Palomar Health, and Temecula Valley Hospital. Unfortunately, Dr. Melanie Fiorella could not join us today, but we wish her and her family all the best. So if you'd like to get started.
So thank you for having me. My name is David Neeson. I'm first and foremost an emergency physician. Since 2006, I worked at various practice settings across the country, but I've been at Kaiser now for almost 9 years. Right now, I am assistant chief of my department, but most of my career at Kaiser and before that was in the field of disaster preparedness and emergency management, which has kind of brought me here today. Obviously, there's a lot of overlap with wildfires, violence, infectious disease, and all the things that we prepare for that have a lot of relationship to a warming climate. And so that's what got me introduced to it. I realized that that is just kind of the tip of the iceberg, probably not the best pun for today, but as it relates to all of the effects of climate and health. So we're going to talk about some of those. I apologize if any of our material has been covered in other venues. We haven't had a chance to go to each and every one, but I look forward to the recordings. But we're going to talk about heat and as it relates to the emergency department overcrowding, which, as I'm sure many of you know, is happening. So I wanted to start with a case, as I often do. So, and this is based on patients which I have seen both at Kaiser as well as Sharp Grossmont. I have an 82-year-old Asian American male brought in by medics, presents after being found by his granddaughter at home with altered mental status lying on his couch. Last seen normal 2 days prior, no signs of trauma. You see his past medical history, significant for hypertension, coronary disease, and a stroke. He's on these medications, which include an antihypertensive, a diuretic, aspirin, and a statin for cholesterol. He lives at home or lives alone in a private home in Descanso. For those who are not local or haven't been out there, it's out east, kind of near Cuyamaca State Park. Former smoker, drinks 3 to 8 beers per day. Due to wildfire risks, SDG&E has turned off the utilities 2 days prior. And then you see his vital signs, which show some tachycardia, hypotension, tachypnea, hyperthermia. And on exam, he is obtunded, altered mental status, diaphoretic, modeled, with no focal neurologic deficits. So any thoughts? We would like for this to be interactive. Any thoughts on what could be going on? Not a trick question. Exactly, yeah. So this is classic heat stroke. Obviously, with this presentation and an elevated temperature, you would think about infectious causes, toxic causes, potentially trauma. But this is what we're here to talk about today. So this is classic heat stroke. Exertional heat stroke can also occur in younger individuals as it relates to exercise, but classic heat stroke is very common in the elderly. Does anyone know what makes this heat stroke versus heat exertion? What's the critical difference? Just like the name implies, it's a central nervous system change. So I don't want to bore you guys with too much pathophysiology, but it's really important to think about the ways that our body cools itself. There are 4 main methods. The most prevalent or the most important one is evaporation. And what we do in the emergency department when someone comes in with heat-related disease is we focus on primarily convection and evaporation. Most of it involves kind of misting a patient with lukewarm water and turning on fans. And that's primarily what we do first, rather than anything more invasive. Keep in mind that once the humidity gets above 75%, the body's ability to use evaporation really goes down the drain. And if you have noticed, the last few days in San Diego, we've been up in the 85, almost 90% humidity. And then the other forms, convection, radiation, and conduction, are only effective when the environmental temperature is less than the body temperature. So once we start to get to triple digits, none of these mechanisms work, and that's why people end up in trouble. So we want to just do some quick definitions. What is an extreme heat event? It's weather that is substantially hotter and or more humid than average for a location during a comparable period. So it really depends where we're talking about. So an extreme heat event in Dubai is going to be very different than an extreme heat event in Vancouver, Canada. If you remember, I think it was 2 summers ago, there was this heat dome over the Pacific Northwest that killed hundreds of people. That level of heat would probably not result in as much mortality in a place like Phoenix, but they don't have the infrastructure, they don't have the cooling, they don't have the community outreach and all the things that we have in warmer climates. And also keep in mind humidity. I come from Texas, and there's a saying there, it's not the heat that'll get you, it's the humidity, but there is some truth to that. For example, 88 degrees at 95% humidity is the same, or feels the same, and has the same physiologic effects as 121 degrees at 10% humidity. And San Diego is getting warmer. We see extreme heat events in San Diego more throughout the year, and it even varies across the county. As this gentleman was in Descanso versus, say, Carlsbad, an extreme heat event in Carlsbad might be 90 degrees, whereas that's a routine summer day in East County. So extreme heat events. Again, my background is in disaster medicine. This maybe isn't the most glamorous, doesn't get the best photos on the news, but this is the most common cause of weather-related human mortality in the United States. It's responsible for more deaths annually than hurricanes, wildfires, lightning, tornadoes, floods, and earthquakes combined. So just kind of looking at a little bit of data, all of this has been quantified. This particular study looks at ICD-9 and 10 codes, which are diagnoses in the patient's chart, and looks at the years between 2008 and 2020. And it basically showed that it was highest in July, as you'd expect. It was regional. Most common ED visits related to heat-related illness were in the South, but there were growing numbers in both the Northeast and the Midwest, because these are areas, again, that are not built for the kind of heat that they're now seeing. And this shows kind of the summer peak, as you'd expect. But this really doesn't tell the whole story, because all of these numbers are looking at specific heat-related illness like heat stroke, heat syncope, and heat exertion. But that doesn't really tell the whole story of all the increase in ED visits which occur. So what do extreme heat events increase? They basically increase everything. Dr. Castellanos went through a lot of the cardiovascular issues. We had a pulmonologist who discussed respiratory, obviously heat-related illness, but things that you wouldn't necessarily think about. So preterm labor, trauma, interpersonal violence. Dr. Melanie Fiorella can't be here today, but she had some great information about that, so you'll have to wait till next year to see that. But psychiatric illness exacerbations increase, suicide attempts and completions, acute kidney injury as you vasodilate, you drop your blood pressure and you drop your perfusion to the kidney. That's very common. You also have tremendous electrolyte disturbances, especially if you're replacing with free water. And most importantly, it results in increased visits in the ED and increased mortality. So this is kind of the crux of the whole talk, and we could spend the entire talk going through each of these, the physiology of each, and then presenting you data on why each of these things occurs and how much it occurs. But we're going to focus more on what we can do as clinicians and community members and family members, and focus on who is vulnerable. Maybe this is faux pas to show a UCLA heat map, but this is a really interesting map that shows the excess daily emergency room visits from extreme heat across California. You can see that San Diego is amongst the highest, and if you do the math, that's saying at about 800 to 850 excess ER visits in the county occur during an extreme heat event. But you can click and get rather local with this. So who is most at risk? We've talked about this in previous lectures, but the elderly, those living alone, those without access to AC, obesity, cardiovascular disease, neurologic or psychiatric disease, athletes, and those who perform manual labor. And it's not just those who work outside. When my first job was in North Carolina after I graduated from residency, and we saw a lot of heat-related illness from a chicken factory, which was up the road. That this place was built before heat was an issue like it is now, and these people just work in very inhumane environments. And then Dr. Castellano mentioned the homeless, which I think is really important. I left that off the list, but that's very important. We also want to look at medications and other risk factors. So diuretics dry you out. They inhibit the kidney's ability to retain water. Antihypertensives can inhibit the cardiovascular response to heat. Anticholinergic drugs as well, and certain antiepileptics. Alcohol as well is a diuretic, also causes increased vasodilation and other neurologic issues which may impair your response to cooling, and then sympathomimetics. And then I wanted to introduce the concept of heat islands. Has it been introduced in other lectures? A little bit? Okay, so this is really important, and this shows really why there are more vulnerable groups. But a heat island is an urbanized area with limited greenery and a lot of streets and sidewalks and buildings which actually re-emit the heat and the sunlight back into the area. And this actually creates much more heat in urban areas, and also a lack of nighttime cooling, which is very critical for the human body to recover. And I wanted to mention this slide. My wife hates this slide. It's rather busy, but I think it's extremely important to kind of show when you're talking about any risk factor for certain communities, any insult, whether it's climate, whether it's COVID, whether it's gun violence, whether it's opioid crisis, you want to look at three things: the exposure, the sensitivity, and the adaptive capacity. So, and that really defines who is most vulnerable. So those who have the most exposure are those who live in heat islands, who don't have access to AC, those who work in the heat, who are elderly. And then sensitivity, the person's own physiology is going to be much more susceptible to the effect of the heat. So again, cardiovascular illness, obesity, diabetes, and then adaptive capacity. What ways do they have to combat this? Do they have social isolation? Are they someone who lives alone, who can't escape the heat, who doesn't have access to AC, who doesn't have access to healthcare? So that really defines our vulnerable groups, one of which is children. Good segue. Thank you. Thank you.
All right, everyone. I'm Brittany Voth. I am a second-year resident with UCSD and Rady Children's, and I have an interest in doing pediatric emergency medicine. So a lot of what I'm going to talk about has been mentioned in other talks, particularly if you went to the extreme heat and the child talk, but it'll be a good summary of everything. So we talked a little bit about the physiology of adults mainly today, and how they respond to heat. So there's this big discussion: is there even differences in adult versus child responses to heat? And honestly, the verdict is still out. Some people, including the AAP, says that there are no differences, that the child response to heat is very similar to the adult. Others disagree, which is what the little infographic shows about how the body surface area, the blood volume, sweat production, and all of those can influence how a child is able to respond to heat in terms of evaporation with sweat and things like that. So still need to do a lot more research to try to, clear that up a bit. So we're going to do a case study, and this is a very similar case that I actually had just a few weeks ago. It's a 4-month-old full-term, previously healthy female with her immunizations up to date, who presented to the ED due to a seizure at home and then was being just lethargic, sleepy, not her normal baby self. While in the ED, she has another seizure. So it's a witness seizure. Her initial labs were pretty normal, except she has a really low sodium of 116. We give hypertonic saline, the baby stops seizing, and she's admitted to the PICU for monitoring as we, slowly normalize her sodium levels. So what do we think caused this hyponatremia or low sodium in this infant? Does anybody have any idea? Okay, dehydration. Yeah. So one of the things we see a lot, which a lot of, especially like grown-up medicine doctors don't think about as much, is, so San Diego is having their first big heat wave. There's no air conditioning at home, and the parents just kept giving her bottles of cold water because they didn't want her to become dehydrated. But an infant's kidneys aren't able to concentrate sodium like a grown-up's are. Therefore, it kind of just dilutes everything out and they end up hyponatremic. Pretty much if we get an infant into the emergency room that's hyponatremic, the very first thing we ask is, what have you been giving? Have you been giving just the formula and breast milk? Have you been giving water? And then even how are you mixing the formula? Because if they're doing too few scoops to water, and so it is a little bit diluted, they're going to end up hyponatremic. So just kind of talking more about babies, because again, they're unique. And babies in particular depend on a lot of those environmental factors for thermoregulation. So when it's hot, they need light clothing, they need extra fluids, but not necessarily water. And then they don't really have effective sweating. So they need the air, they need the convection in order to lose heat. So something else that we see is parents will cover the stroller on long walks with a blanket so that the sun isn't on the baby, but that means there's no airflow now. And so the baby's just in this little oven and they get really warm. This little picture of heat rash is probably one of the most common questions we get about infants. And again, it's just their little sweat glands are too immature to keep up. And so they get overworked and clogged, and it causes this heat rash if they're too warm. Moving on to older kids, student athletes. So the likelihood of a heat-related illness or death is 10 times more likely to occur in this preseason conditioning time. So it's after kids have been, relaxing at home for a month or two, and now they're starting football practice, things like that. And so they just don't have the conditioning yet. So in the last couple decades, at least 50 high school football players have died from direct heat-related illness. And our highest risk sports are football, which kind of makes sense with the pads and the helmet, just the amount of gear. And then also cross-country running, which is another fall sport that does a lot of summer preconditioning. These are two 16-year-olds who in the last couple of years have unfortunately died. On the left is Zachary. He is a football player, and he died during preseason conditioning in Florida with a heat index of like 105. And then Imani, another 16-year-old, died during basketball practice with another heat index of 103. So what are some of the risk factors in children? Something else is a nonverbal child, whether it's just because they're a toddler who's not speaking yet or has some sort of developmental delay, autism, etc., won't necessarily ask for water if they're thirsty. Us as grown-ups, if you're thirsty, you just grab water and drink, or you're able to ask someone, hey, I need a glass of water. So it's something that if parents aren't really paying attention to how much their toddlers are drinking, they can get very dehydrated. We talked a little bit about the medications. And so we have a lot of kids who are on stimulants for ADHD. That puts them at higher risk. Less time acclimating. So ideally you need about 2 weeks of a gradual increase in exercise. So for football, the suggestion is like for the first few days, no pads. Then you do a couple days of helmet and no pads. And then you kind of gradually build it up as they acclimate. Not enough recovery time. Again, in football, 2 a day practices are
very normal. But if they're not having enough time to rest and recover between very strenuous practices, that puts them at higher risk. Excessive clothing and gear, again, football, obesity, sickle cell disease or sickle cell trait, and then any kid with metabolic disorders. So some secondary effects of this increasing heat on kids. Things that we don't necessarily think about are things like fatal and non-fatal submersion drownings, hot car deaths, and then asthma exacerbations, which has been talked about in a previous session. But starting with asthma, this was a big study done at Children's Hospital of Philadelphia, looking at the summer months over like a 5-year period and seeing what the difference were in terms of asthma exacerbation events. So they were able to show that if the high mean daily temperatures were, on the higher than 95th percentile for that period, there was a statistically significant increase in asthma exacerbation presentations to the ED. The most substantial differences they saw were the ages 2 to 5, and then also in Hispanic and non-Hispanic Black children. Interestingly, when they adjusted for air pollution, allergens, respiratory viruses, and things like that, it actually didn't really change the estimation, which led them to conclude that heat is really the primary driver of these asthma exacerbations and not necessarily increase in air pollution or allergens. Drownings. Every year, there are more than 4,000 unintentional drownings and 8,000 non-fatal drownings. It is the number one injury accidental cause of death in ages 1 to 4. Florida, Arizona, and Louisiana have the highest rate of pool drownings. And in Florida, 22% of all deaths for ages less than 5 are due to drowning. And then highest in June, July, and August months. The little table shows that while there is a little bit of a decrease for a while in like most of the age groups, it was because of like pool fences and more education and things like that. But there really hasn't been a decrease. This is still happening at the same rates as it always has, and I really haven't made much progress in this. And then the other little one is like a parent information about things you can do to make it safer. Oops. Hot car deaths. So in the US, 33 children died in a hot car last year and 16 already this year. So parent education and things like that have decreased these front seat passenger airbag deaths. Everyone knows a little warning if a kid's under the age of 12, they shouldn't be in the front passenger seat because of the airbag. But the graph shows that while, yes, it was a problem and then it was addressed and now it's gone down to nothing for the airbags, nothing really, again, done about these hot car deaths. And they are just as, steady as they were before. And, so we see a lot of these things where outside it might only be 75 degrees. And so you don't really worry about like, oh, I'm just going to leave. My kid is napping. I'm just going to go in for 20 minutes, be right back. Well, in that 20 minutes, the inside of the car could already be 105. And they're in this enclosed space with no, way of cooling. And that's what leads to the hot car deaths. So how does all this impact our emergency room visits? There's a 2022 study that looked at almost 4 million pediatric ED visits across 47 hospitals in the United States. And altogether, the extreme heat was associated with an increase in ED visits, more pronounced association for anything that was a heat-related illness. So that's, again, your heat strokes or heat exhaustion, things like that. Also including dehydration and electrolyte disorders, but also things like bacterial enteritis and ear infections also. So altogether, this heat-related illness accounted for 31% of all of the ED visits during the warm season. And then as you can see in the infographic, you can kind of see the areas where we're seeing more heat-related ED visits. This is just another kind of representation of that same data, showing that again, heat-related illness is the big one, but then also seeing bacterial enteritis, ear infections, and things like that. If you go towards the bottom, like fourth from the bottom or so, you have asthma, which they actually did not see an increase in asthma exacerbations to the ED during this time period. So I find that interesting because almost every other study shows the opposite, but this one did not have a statistically significant increase in asthma exacerbations. So that is what I have for kids.